Today we're going to talk about trauma diagnostics. Objectives for this will be to understand the triage diagnostic approach in trauma cases, to understand point-of-care diagnostic interpretation, including packed cell volume and total protein, glucose, and lactate, and additionally to understand the indications and techniques associated with focus assessment with sonography in these trauma scenarios, also called FAST scan. One thing to keep in mind as we talk about point-of-care diagnostics is our patients that present in trauma scenarios during triage and assessment, we often place an IV catheter for IV access, fluid resuscitation, medication administration, and blood work for our point-of-care diagnostics can be drawn during that placement of the intravenous catheter. When we talk about what blood to draw in our minimum database in these trauma scenarios, we'll think about and talk about packed cell volume, total protein, glucose, lactate, and if available, blood gas or I-stats can also provide us a lot of information. Packed cell volume and total protein are easily performed, require hematocrit tubes and a centrifuge, and they should always be performed together. In our trauma scenarios, most patients will present with normal packed cell volume or total protein numbers, and the reason for that is during these acute trauma, hypovolemic shock, hemorrhage, our patients that are hemorrhaging are losing packed cells, protein, fluid, all at the same time. And so it will take a while for fluid redistribution for our packed cell volume to really reflect that degree of hemorrhage. However, total protein can provide an earlier indication of acute hemorrhage. PCV often doesn't nadir, again, for about 24 to 48 hours after trauma, versus total protein can decrease sooner. And so, if we have a patient present with acute trauma that is a total protein less than 6, that should pique our interest that we are worried about hemorrhage, whether it's external or internal. Glucose is also a very helpful point-of-care diagnostic in our trauma scenario. It is bedside and can be performed on a glucometer. And hyperglycemia can give us indications of things like severe shock. Hyperglycemia is common in severe shock or severe stress. Another reason that it can be helpful is in conditions such as traumatic brain injury. Hyperglycemia has not been associated with outcome in traumatic brain injury in our veterinary patients. However, it has been associated with the degree of injury. So, for example, if we have a traumatic case present to us and we're concerned about traumatic brain injury and they are severely hyperglycemic, that can be indicative of more severe injury than a patient that is normoglycemic on presentation. So it can just give us some information about the severity of trauma and shock when our patients present. Lactate is also helpful in terms of our point-of-care bedside assessment. Lactate's a product of anaerobic metabolism and will increase with inadequate tissue oxygen delivery. Inadequate tissue oxygen delivery in shock states are going to be very common in our traumatic cases. And so it can give us information about the severity or degree of anaerobic metabolism that's occurring due to inadequate tissue oxygen delivery. It can also be utilized in goal-directed therapy. So while lactate can give us an initial assessment of severity of injury, the biggest, most helpful part of lactate is actually looking at how it changes over time and how it responds to our therapeutic interventions. So one of our goals in our trauma resuscitation is normalization of lactate, and watching our trends in lactate can give us an idea of how our patient is stabilizing or responding to our interventions. Again, we won't talk as much about blood gas or eye stats because that might not be a readily available test, but if it is, it can provide a lot of information in our trauma patients. One thing in particular is ventilation. Carbon dioxide levels are often present on our blood gas or eye stat, and it can give you information about ventilation. Is our patient hyperventilating? Potentially they are hyperventilating because they are painful, or they might be hyperventilating because they are hypoxemic and have thoracic trauma. On the flip side, we might see evidence of hypoventilation that can be associated with traumatic brain injury or other types of injuries as well. So ventilation status can be obtained from a blood gas. Electrolyte and acid-base status can also be helpful. Some of the trauma that we'll talk about, we might see abdominal trauma like a uroabdomen. A uroabdomen is going to result in electrolyte abnormalities, which we can see on a blood gas or an eye stat. And additionally, those perfusion parameters that we talked about with lactate can be present on a blood gas as well. In addition to those blood work point of care diagnostics, another extraordinarily helpful tool in the trauma scenario is our focused assessment with sonography, or our FAST scan. It's a point of care ultrasound, so sometimes terminology that will be used or heard will be POCUS. Any trauma, blunt or penetrating, is a good indication to perform a FAST scan. When we talk about FAST scan is divided into thoracic FAST scan, TFAST, or abdominal FAST scan, AFAST. And anytime we're bringing out the probe to evaluate our trauma patients, we should always evaluate both our thorax and our abdomen. One thing that is extraordinarily beneficial about a FAST scan is that it can be performed in any position. I put positioning sternal. It can be performed in any position. The reason I put sternal here is if we have a patient that we're worried at all about their respiratory status, thoracic trauma, or oxygenation, patients will oxygenate better in sternal recumbency, so this can be performed in sternal. It can also absolutely be performed in lateral if our patient is more comfortable in lateral or we're worried about neurologic trauma. That's fine as well. So any position, we can get these images. There's a few different approaches. We're going to talk about 5 main transducer sites, and when we talk about lung ultrasound, we'll talk about ultrasounding the lungs in a little bit more detail. But essentially, FAST scan will be performed on both thoraxes. So left and right hemithorax, we'll look at several different spots. So one is the pericardial site. So this is going to be directly over the heart, again on both the left and the right. Our chest tube site, which is going to be over the lungs. We'll talk in more detail about multiple sites of the lungs. And then also DH, or diaphragmatic hepatic. So that's our subcostal evaluation that can be helpful, particularly in our deep-chested dogs. So here's an image of a dog. Again, sites that we're going to be looking at. Pericardial is going to be directly over the heart, both on the right and left. And chest tube site is going to be over the lung. And if we were going to be performing diaphragmatic hepatic, we'd go in this subcostal space. Things that we are evaluating when we perform thoracic FAST scan. Number 1 is the glide sign. So a glide sign is a normal finding. It is the to and fro motion of the visceral and parietal pleura as our patient breathes. So again, it's a normal finding at our pulmonary pleural interface, and lack of a glide sign is what's concerning in our trauma scenarios and can suggest a pneumothorax. So in these images, we see rib shadows. They'll also be called gator eyes. So we see rib shadow, rib shadow. A lines are normal reverberations of our ultrasound. We can't actually see pulmonary parenchyma due to the interface of gas. And then we're looking up here for a glide sign. So again, that motion. So here's an image where you can see a glide sign. So rib shadow, and this little etch-a-sketch line moving back and forth is a normal glide sign. Next thing that we evaluate is for pleural effusion. So effusion is going to appear anechoic or hypoechoic. And in the pleural space, it can appear triangular. It surrounds the heart and lungs. It might even have some fibrin or atelectic lung floating around. We can also evaluate the lungs themselves in a little more detail. So here is an image where we would evaluate multiple areas of the lung: cranial, middle, perihilar, and caudal. So we're trying to use our ultrasound to evaluate multiple areas. And one thing we're looking for in particular is abnormalities of the pulmonary parenchyma. So here is an image of a normal lung ultrasound. So again, we see rib shadow, rib shadow. We see our nice Clyde sign up here. And then these are what's called A lines. So normal reverberations of our lung ultrasound interface that indicate no specific abnormalities of the actual lungs. When we are doing our lung ultrasound, one of the main things we're looking for is B lines. B lines are small fluid-filled alveoli that are below the resolution threshold of the ultrasound. So what they essentially look like are discrete, narrow, hyperechoic, laser-like lines that we see that begin at the pleural interface and then go to the far edge of the screen. These are these bright white B lines. So normally we're just seeing those A lines, but these two images are showing us those bright white lines that begin at the pleural interface that extend all the way down. So those B lines are going to be indicative of fluid within the alveoli. That can be any fluid, but when we talk about trauma, our top suspicion would be some sort of hemorrhage or contusions within the lungs. So here are some additional videos. So this video over here, we're seeing pretty normal lung tissue. We see our rib shadows. We're not seeing those bright white laser lines. Versus in the second image, we're seeing what we would actually call infinity B lines, but we're seeing multiple bright white laser-like lines that are obliterating those A lines. So again, that would be indicative of fluid within our alveoli. Technique. One benefit is it can be performed rapidly. Fast scan is as good as radiographs in identifying free fluid. It's fast, it can be performed while we're stabilizing our patient, and doesn't risk destabilization or stress of performing radiographs. It's a 4-view protocol, which looks at 4 quadrants in the abdomen, known as subxiphoid or diaphragmatic hepatic, splenorenal, cystocolic, and hepatic. So 4 quadrants of the abdomen. So diaphragmatic hepatic or subxiphoid is our cranial abdomen, splenorenal is our left abdomen, hepatorenal right, and cystocolic is caudal. So again, here's images that we would perform. We would perform our thoracic fast scan, looking at heart, lungs, and then our abdomen. We're looking in these 4 quadrants and looking for that anechoic free fluid. If we do find free fluid, it's helpful to score it. So essentially what we're saying is how many of those sites are positive. If we have 4 standard views, is it present in 1 view, 2 views, 3 views, or 4 views? Because it can be indicative of the amount. So if we have a patient present that has 4 out of 4, and we're concerned about a hemoabdomen, it's more severe hemorrhage and they might require blood product administration versus a patient that had an abdominal fluid score of 1. It can also be helpful in trending. So if you have a patient present and they have a 1 out of 4 fluid score and now it's a 3 out of 4, that might be indicative that there's ongoing hemorrhage or ongoing fluid accumulation. And then in these cases, if we see effusion, we always want to perform a diagnostic abdominocentesis because we want to know what type of fluid it is. And we'll talk a little bit more about the types of abdominal trauma we might see. So overall, the combination of point-of-care diagnostics, which include packed cell volume, glucose, lactate, blood gas if we have it, and fast scan can give us a lot of information about the different types of trauma and the severity that we will see in these cases.